Thank you.
Brilliant.
Hello everyone. My name is John Williams, and I am the stroke performance analyst at Maidstone Hospital. And I'm going to talk to you today about modeling the hyperacute and acute stroke pathways using discrete event simulation with the aim to reduce cost and improve patient care at the same time. So before I go on, I'll talk a bit about my experience before HSMA 6. So prior to enrolling, I had no coding experience at all. I'd thought about it, but never actually done anything about it at all. So I'm an economics graduate, so I have some understanding of statistics and econometrics, but if you quiz me on it now, I probably wouldn't remember anything other than the names. So some statistical background, but it's not looking great for me at the moment there. So I'm self-taught in Microsoft Excel, and throughout my professional career, I have mainly used this to analyze data, produce dashboards, and make any other data-related things as well. And a funny story with this, I was so passionate about Excel before the course, my manager suggested I come to the last open day, and on the title slide with all the music playing, it said, "Where we're going, we don't need Excel." And I actually screenshot it and sent it to my manager saying, "What have you done? I can't leave my beloved Excel behind." And within half an hour, I think, I was, trying to sign up to the course. I was like, "This is amazing. This is so much better than Excel, so much more than I've ever been able to do in it." So definitely 180'd me there. So everything we're about to see model-wise, I couldn't have done without the amazing support and training and resources from HSMA. So before I sort of dive into the model, let's talk about the problems facing stroke units across the country and probably worldwide actually, but focusing mainly on the UK here. So in the UK, the rate of strokes is increasing far faster than the population is aging. So it is obviously the aging population is one of the things that is causing this rate to increase, but this increase in the number of strokes is far outpacing that. So some studies have put the increase from around 60% between 2015 and 2035. So that is not a small increase at all. So this figure on the right here is showing our local data at Maidstone Hospital, where I work. And you can see real data from 2018 up until 2023, and then a forecast beyond that point. So even in the actual data, you can see this increase happening. The averages per month going from, high 70s to mid 80s to over 100 to 120, and this is forecast to keep going up and up and up. So this is definitely something that is happening, and it is happening quite fast as well. So in the terms of, building new stroke units, 10 years is not a very long time. So in addition to this, the NHS is under constant pressure, well, even more pressure now than ever, to reduce its costs. So this is a real big problem doing both these things at the same time. You're facing an increase in the number of strokes. You're being told you must reduce cost. How can you do both these things without, reducing cost, reducing care? You can't keep both higher, or that's what it seems on the service as well. And why this is particularly problematic to stroke units is that the pathways flow is everything. So if the pathway does not flow properly, if patients cannot access what they need at the right time quickly, then their recovery from the stroke is going to be not good at all compared to someone who was able to access these resources quickly. So the phrase you hear a lot in the stroke world is time is brain. Every minute post-stroke, you lose millions of brain neurons, so it really, really matters. And if your pathways stop working, it is the people who have just had their stroke who will end up waiting hours and may miss their time-critical interventions and have poorer outcomes. So it really, really matters, and keeping that flow working is so, so important. So, as I just said, these two aims of improving patient care while reducing cost seem to oppose each other, as you cannot, well, on the surface, it seems you wouldn't be able to do both at the same time. You could reduce cost and patient care would decline, or you could increase cost and increase care, especially when you're dealing with an increase in demand as well. So, is there a way to do both at the same time? And if so, how would we explore this? How would we present this information to people who can actually make the decisions? Using discrete event simulation, or DES. So what is discrete event simulation? Just a very quick, very oversimplified background of it. It is a method of simulating behavior and performance of real-life processes. So in our case here, we're looking at the acute and hyperacute stroke pathways, and focusing very particularly on the start of that. So the patients getting admitted to hospital, being reviewed, having all their treatments, and then how that pathway flows. It is far more powerful than traditional forecasting because it allows the user to change parameters and model it, and you can see what these changes do, as opposed to traditional forecasting, which is basically taking the past and pushing that into the future. We could look at what happens if the patients increase, the number of patients increase by 50%. What happens if we put on an extra nurse? What happens if we had more or less beds? And actually see what that does. Obviously, it is not perfect, but the idea is to get it as close as possible so that it actually shows to the stakeholders this, like the reality of what is happening. So while the problem facing stroke units, especially in the number of strokes increasing, is definitely, it is not unknown and it's been known about for quite some time. I can only speak, I suppose, for myself, trying to show people who make these decisions this happening are using traditional models, just Excel dashboards, normal data analysis. It is not powerful enough, and it doesn't drive change. People kind of either ignore it or they're a bit apathetic to it. They're like, oh, that's not good, question mark. However, even from this model, which has only been shown in the last month or so, it has had a far greater engagement from these stakeholders. I've had people who normally kind of ignore the models I make chasing me down and saying, can you show me this? Can you show me this? And all that. So it has a much bigger impact, and it is much more powerful than these more basic, just having a dashboard, for example. So in terms of data sources, I've used data from the Sentinel Stroke National Audit Programme, locally collected data at Maidstone Hospital, as well as some general research on stroke to back up things that we were observing in our own data as well. And then using that in this model to see how these patients will flow through these pathways and what the result will be from that. So there are two very key areas we're going to be looking at in this model. And these are where most of the care improvements come from and the cost savings. So getting both these together at the same time. And the main driving factor behind both of these are same-day emergency care, or SDEC in stroke, and the use of CT perfusion scanning. I always like this picture because we're so fast in the SDEC, it's like strapping rockets to your patient, which isn't a good idea in real life, apparently, I've been told. So we're going to focus on the SDEC in stroke first, and this is the picture of our SDEC at Maidstone Hospital. So SDECs in stroke, there are no formal models on how this should be done, though several trusts, including our own at Maidstone, have begun operating them, though obviously there is variation in how they're being implemented. I think the benefits are quite easy to imagine, but there's no formal structure, so everyone's coming at it from different angles. So we've had a stroke SDEC in Maidstone since 2020. So ours is one of the most developed, as in mature, and has had the most time to sort of be audited and all that stuff as well. So when we've run these audits, every time critical intervention in the stroke SDEC is statistically significantly better than not in the SDEC. And this is on the background. We were doing this analysis when we had enormous building work going on in the stroke unit, expanding the bed base. So you'd expect it to be worse, but it was better in that building time than it was before without that. In addition to that, while we've been operating our SDEC, our official SNAP grade, so our National Stroke Audit grade, has gone from a C to an A. So it's very, very impactful in performance, but also in patient care. And the key thing to take away from this, the model I will show you is very focused on cost, and it does measure patient outcomes using an MRS tool, which I'll go over a bit later. But the key thing to take away from this when you're looking at the model is patients that go through this SDEC have better outcomes. They are seen faster, they have treatment faster. And while this is an SDEC, it is located on the stroke unit and is staffed at the same level as the stroke unit. So you do not miss out on anything by coming through this SDEC. You receive all the same care you would have done by being admitted to the stroke unit in a traditional sense. So the idea behind this is that while it is operational, all patients will pass through the SDEC, and those who require further care, therapy mainly, will be admitted onto the ward as most patients would have done through A&E, but those that can be supported by clinics or by community therapy, or just maybe don't need anything at all, can be discharged on the same day. This really, really helps ward flow. It also saves the cost of a bed day, which when you're running a stroke unit, the cost of your hyperacute beds is probably your biggest cost. So if you can avoid admitting patients to them, but discharge them safely and support them in the community, better for the patients. No one likes being on a stroke unit. So if you can have as good a therapy at home, that's a win. And the financial side as well is obviously that you didn't have to occupy that bed. It didn't block the pathway for someone who really, really needed it. So that is, we run our SDEC currently 8 till 8. However, no one that makes decisions really wants to extend this because there is a cost in running it, which at the moment is one doctor and one care support worker who otherwise wouldn't be employed. Everyone else who works in there would have been employed anyway because they would just be on the stroke unit or A&E rather than the SDEC. So there is a cost to extending these operating hours, which has suppressed the desire to do this. However, from this model, we can look at whether the savings from the admission avoidance, the bed day savings, is greater or great enough to sort of just make those costs not matter. So next I'll talk about CT perfusion, hard to say, which I'm going to call CTP for the rest of the time, and thrombolysis. So thrombolysis is a clot-busting drug that is used to treat ischemic strokes, which make up 80% of strokes. Patients who receive thrombolysis have far better outcomes on average than those who don't. This is very well known in the stroke world. And again, in this model, you just have to be remembering that if patients are having more thrombolysis, it is good. The model will be talking a lot about money rather than the outcomes, but both these things, the SDEC and thrombolysis, they are really, really good things if you have more people going through them. So the problem with thrombolysis is it can only be administered within 4.5 hours of onset from the stroke onset. Meaning one, that the patient either has to remember when the stroke happened, which is not always possible. Someone has to have seen it happen, which again is not always possible. And a lot of strokes happen at night, so you don't necessarily even know when it happened. This seriously reduces the amount of patients that can receive thrombolysis because they have to, have been witnessed or actually remember when the stroke happened. So very simply, CT perfusion allows you to highlight if there is any brain tissue that can be salvaged by thrombolysis treatment, meaning you can thrombolyze anyone who has salvageable brain tissue, which usually doubles the amount of patients you could thrombolyze. So again, you have these patients having these much better outcomes. Our ward traditionally without CT perfusion thrombolizes about 10% of our total patients, and that can go up to nearly 30% if you are running CT perfusion the full time. So the problem we have is we do not have the staff required to run it 24/7. So we currently run a 9 to 5 service. I think it's 8 to 5 now. But the point of this model, again, is to back up why we should have the staff. And this is not a staff number, this is the staff training issue, why these staff should be trained to use CT perfusion machine and what the impact on the finances and the ward would be. So the big financial saving here, obviously you have the very important one, which is that patients are made much better off. But the big financial saving is that thrombolyzed patients by majority spend less time in hospital because very simply they are made better. So they are not as ill, so they can go home sooner. And in terms of stroke pathways, they tend to go home with support on faster pathways. Rehab pathways in strokes are very slow with long waiting times. Community pathways, which you go on if you are made better by thrombolysis or just better in general, are much faster. So you have a big bed saving there as well. Again, it all comes back to the cost of these hyperacute beds and how much money can be saved by not filling them or emptying them quicker. So what I was going to do is show you some tables from the model, but what I've decided to do is just risk it and run the model live so you can see. If it is not big enough with the results coming up on here, please let me know. And you've probably seen many, many fantastic interfaces and apps today. I'm afraid this is not one of them. It will be, I will get there. But at the moment, we're going to run it in here and it's just going to make us some tables. So first off, the model is asking, do I want to write the results to a CSV file, which I'm going to put no. I don't want to make graphs because I showed someone this yesterday and they said my graphs were horrible and confusing, which is like a dagger through my heart. So we're not going to show those at all. And I'm also going to say I don't want to run the SDEC with full therapy support, which will increase the amount of patients that could be discharged home. So ideally, what I'd like to do if I have time, which I might not, is do 4 runs of 3 and demonstrate the changes from using an SDEC at different percentages of the day, CT perfusion at different percentages of the day, and then those combined. And if I have time, I can model what a 50% increase in strokes would look like and how many beds you would need or how long you'd need to run the SDEC to accommodate that. So we'll start off by looking at the patient and financial benefits of an SDEC. So we'll create a baseline, which is we will assume we have no SDEC in stroke and no CT perfusion. And once the model has run 5 runs of this simulation, it will come up here with the averages. So as you can see here, the time for queue for a nurse is, 60 minutes is not that great. But the big thing down here is in this configuration with this amount of patients coming through, the queue time for the stroke ward in hours is 192 hours on average. It is very, very unacceptable, obviously, when you're only having, you need to do all these interventions in 4 hours. That is totally unacceptable. We have 49 beds on our ward currently, so it is showing you are full basically all the time. And 1,737 patients had delayed admissions on average. And this is anyone who needed a stroke bed and couldn't immediately get it. In these simulations, it's running about 3,000 patients through it. So that's almost half the patients were delayed in some way. And finally, the MRS change down here. I won't go into detail what this is. It's do with the patient improvement, but a higher number is better. So what we'll do now is I'm going to run again with no SDEC therapy support, but I'm going to increase the SDEC to running 50% of the day rather than 0. And we will see what that does. And I'm just constantly fighting with the Zoom bar because it was getting in the way. It's gone over there now. Good. Right, so trial 2, when it pops up down here, you can see that the number of admissions that were avoided by using the SDEC in that time frame was 322, so about 10% of the patients. The queue time has gone down. It's still pretty unacceptable, but it has gone down from nearly 200 hours down to 47 hours. And very importantly as well is the ward occupancy has dropped, which means that the nurses are having to look after less patients and the therapists are having to see less patients as inpatients, which means they can spend more time with the other patients. So down here as well, we've got the total number of SDEC savings. So this is how much was saved by those same day admission avoidances, how much it costs to run the SDEC. So in essence, it's a saving, but in essence, your profit, as in the savings minus the cost, is 200,000. So you're seeing also patient outcomes improving, you're seeing the ward performance improving, and you've made a saving. So you've managed to have your cake and eat it too. And now we'll go to 100% of the day. So you're running a 24-hour SDEC and we'll see the impact that has. Right, so we're now admission avoiding 789 patients, so a much higher percentage. The ward occupancy is down at 28. This is fantastic for the therapist and ward team if this happened. I mentioned this to a therapist that I was like, oh, wouldn't it be nice if you had half as many patients on your ward? And they're like, oh, that's the dream. And I'm like, well, does it have to be a dream or could you make it happen by extending these hours? Queue time for the ward is now 0 minutes with all patients being admitted straight away. The savings overall have gone over 500,000 and the patient outcomes have increased as well. So overall, you're seeing patient outcomes improving and the cost savings are getting very, very large. So as I'm running out of time, what I'll do is I will condense my next set of runs into one. So we'll do a standard base run again, which will be just a 0-0 across the board. When I was running this on my own as a practice, these waits between the runs and the results coming out were very quick, but they feel quite long now. So that's our same model. So it's going to be very similar to our first one. It is basically a stroke unit that does not function. I'm going to put the SDEC at 50% and the CT perfusion at 50%. So this means we'll be thrombolizing more patients. We'll be discharging a lot of patients as well. So saving a lot of money in the beds and also improving patient outcomes because they're being thrombolized more and having, the ward occupancy is lower. So here, this stuff is very similar to what we looked at before. However, the cost savings have started to shoot up. The thrombolysis savings from using CT perfusion have gone from 0 to 800,000. These are huge, huge savings because the thrombolysis makes such a big difference here to the amount of time patients stay on the ward. And that is the biggest cost of a stroke unit. So I'm now just going to push it to 100% for both. So this is your sort of ideal stroke unit. You're running your SDEC 24/7. You're avoiding admissions when you can. You're getting your flow always good. And you've got your thrombolysis at max. So you are able to thrombolize as many patients as possible so they have better outcomes. So ward occupancy just under 30, which is fantastic, a huge difference from 49 for those people working on the ward. However, if we have a look at the costs, we're now over 2 million savings, powered mostly by the thrombolysis savings, and the mean MRS has gone to the highest number we've seen so far. So it is a all positive outcome. And very quickly, before I run out of time, I will just talk about the impacts. So our CT perfusion scanner is infamous for not working and often doesn't get repaired quickly because of cost. Having shown this model to our management team, they are now going to prioritize this because they can just see it is way more costly to not fix it than it is to fix it. This will also have a positive impact on our patients. As I mentioned a bit earlier, it has transformed the attitude of our senior management team to extending the SDEC hours and also the CT perfusion hours, where there's much more excitement for it as opposed to sort of an apathy towards it. And also this model, I didn't get to show this today, but it illustrates the danger of escalating into your SDEC. So currently what happens is when the ward is very busy, we escalate into our SDEC and it clogs it. So it means that you can't same day discharge any patients, which then creates a cycle of escalation because you can't get patients out earlier. You never empty your ward, so you're always full, which is kind of the state that we're in now. And I imagine a lot of trust in. So it has really made people think about when they should not escalate. It's not the easy out. I haven't got beds, I should put them in here. And also, as money talks in the NHS, especially, there is a financial cost to escalation, which is that your doctor and care worker that you've paid specifically to work in here to help discharge patients is now just not doing anything because they're not doing that part. Well, they'll find something to do, but you know what I mean. They're not being utilized for their intended purpose. In terms of the future, so I'm currently discussing with the senior members of the stroke team about presenting this to our trust CEO to promote the stroke SDEC model, but also to promote discrete event simulation as an effective tool that can be replicated in other areas of the trust. Like if we're able to illustrate that we can increase patient care, we can significantly reduce the amount of patients we have on our ward at a time, and also make savings of 2 million. If that was replicated in other areas of the trust, then, you know, that's very, very good. Everyone is trying to make cost savings, and if we can make them without any redundancies and make them while improving care, that is obviously the best outcome. So the main reason I actually started making this model, and this is starting to come together now, was to support business cases. So to support the SDEC opening hours being increased, as I said before, because there was a cost associated with it, most people were just like, no, don't want that. But also that stretched into therapy now as well. So the therapy team has been able to see that they could actually cut off a load of their work by seeing these patients in the SDEC, reviewing them, and then making decisions then instead of waiting till the next day when they're in a bed as part of their current caseload, which reduces their efficiency. So hopefully some big impact coming up in the future. I do like how it's already had an impact with the CT perfusion scanner, because I was kind of a bit mad by the fact that it wasn't running 24/7. So I'm very pleased with that. But yeah, that's everything from me. I think I might have gone over a time and I couldn't really see the timer, but I will stop sharing my screen there. But thank you everyone for your time.
Fantastic, thank you. Oh God, thank you, John. I mean that I kept sneaking extra time onto your timer, if I'm honest, because there was so much.
I did keep seeing that, and I was like, "Has it gone wrong?"
Yeah, no, I thought we thought we can't cut you off in this because you're just, you know, telling us absolutely fantastic stuff. The impact that's having on patient care, on real lives, you know, already, that is so wonderful to hear. So do you know, ask any question of John in the chat. Do get in touch with John to link up if you know you're interested in doing the same sort of thing in your own organization. You know, just brilliant stuff. Thank you so much for sharing that with us today.